Are you able to hear me, Gilbert?
Yes, Doc.
Okay,
Yes.
sounds good. Let's get today we're going to talk about a diabetes drug and its relationship to COVID. And in fact, what we discovered, or what was discovered in a recent article, was a diabetes drug may decrease COVID-19 death risk in women. Now, what does that mean, and why were people even looking? As you may remember, there's been huge searches for drugs that can help with COVID. One of the things that we talked about several months ago was looking at existing drugs. And this is not the first existing drug that's been examined for this issue. Hydroxychloroquine was a big one for this. Ivermectin is still going on, and I've used both of those. Many others have as well. Why would people be looking at a diabetes drug? Well, you don't have to think very, very hard and very long on that one. But some of the real answer may surprise you. It may have to do with inflammation as much as glucose management. So we'll talk about that in the program today. Before we do, just a quick piece of information, quick internal advertisement on the content that we have. As you know, this channel is all about helping people discover the things that they're most likely to have, not know about, and most likely to kill or disable us. Prediabetes, diabetes, cardiovascular inflammation. The science is out there. The evidence is very clear. Most, over half of docs in primary care roles don't understand enough about prediabetes or cardiovascular inflammation to diagnose it properly, let alone treat it. So that's why over 90% of us that have prediabetes, diabetes, burning our arteries, creating major risk for heart attack and stroke, over 90% of us that have it don't know it. So, and if your doc's ever said, you have a touch of sugar, be very afraid. Don't pass go. Start getting help now. And it's frustrating, but it's true. It's a caveat emptor, buyer beware in terms of medicine in this space. So that's why we've developed content around the areas where doctors are most likely to just not be aware. We've got webinars on them. This is the information on the webinars. We've got courses on them. So you don't have to go to a webinar. The courses are far less expensive. The webinar is $300 to $500. But you get actual voice-to-voice discussion and question and answer kind of access. With the courses, again, in a couple of hours, you can know more than the typical primary care doc about insulin resistance, prediabetes, diabetes, plaque evaluation, cardiovascular inflammation, and just an overall heart attack and stroke prevention program. We've got subscription programs. We've got other types of programs. We've got a book coming up. Todd's doing a lot of work, and I'm not making any more promises on when it's coming out, but we're still making progress. Most of the progress at this point is clearly due to Todd. The bottom line on that is most of us, up until just a year or two ago, and unfortunately still, most of us think that if you're worried about heart attack and stroke risk, especially heart attack risk, you go get a stress test. Hey, doc, why don't we get a stress test? Well, a stress test is only positive if you've got enough plaque in your artery to slow down blood flow, to impact blood flow in the artery. And that's an assumption. That's an obvious assumption. It's an assumption which relies on something that we all deal with every day, and that's plumbing. But this is not a plumbing problem. 2/3 of the people that have a heart attack, they all have plaque, but they don't have enough plaque to cause a change in the blood flow of the heart. So obviously a stress test is not the way to get an understanding of your heart attack and stroke risk. And that's what this book is all about. If that's not the way, why is it not the way? Should it be a cardiac cath? No, it shouldn't be a cardiac cath either. What are the ways to evaluate it? All of this information you can find on our website. So now let's go to the program for today. Yes, a diabetes drug may decrease COVID-19 death risk in women. Number one, why in women? Number two, why a diabetes drug? Well, and number three, why do we say may? Why do we not say it does? Let's cover the may first. It's a signal. It's a signal as opposed to an unmistakable evidentiary fact or evidential fact. It's when you're looking at science, you look at signals versus clear trends. There's not a clear trend that we can talk about yet. Why did somebody look at this? Well, for most of us, as we think about this, and most of us that have spent any time on this channel, it's really clear why they would look at this. Obesity, which drives insulin resistance, prediabetes, and diabetes itself are major risk factors for COVID-19. Not major risk factors for infection with coronavirus, but major risk factors for the cardiovascular cytokine storm that happens with a lot of people that turns a relatively mild coronavirus infection into a trip to the ICU and perhaps death. So if those two things are so related, there's a drug that's very common, very safe. Does that drug actually impact the potential, the risk associated with coronavirus infection? And the answer is it certainly appears to do so. Now, this is an article that covers this. This was a study done by, we'll talk about who did it in just a minute. It was published in one of the Lancet journals, Lancet Longevity. It was published in December 2020. The title was Metformin and Risk of Mortality in Patients Hospitalized with COVID-19. It was a retrospective cohort analysis. Basically, that means it was done after all this happened. They went back and they looked at, we'll talk about who they looked at. They looked at the cohort. A cohort is it's an old Roman term. If somebody came into a unit of the Roman army, that unit was called a cohort. So in epidemiology, a cohort is a unit or a definition of a population of people. Now we'll describe the unit or population of those people in just a minute. But before we do, let's do a little bit more introductory comment about this study. So it found an association between metformin and a significantly reduced, now significantly, we're talking about statistically here. They saw a reduction for men and women, but for the total population, it was not statistically significant. We'll talk about that in a minute too. But they found a reduced mortality, death rate, in women with type 2 diabetes or obesity who were hospitalized with COVID-19 and were on metformin. Metformin, again, as we know, it's a first line, most commonly used first option medication for treating type 2 diabetes. Now, we'll talk a little bit later about mechanism. Most of us, when we think about metformin, we think, well, it stops a thing called, or slows a thing called gluconeogenesis. That's a long, geeky Latin type word for, let's break it down, meaning glucose or sugar in the blood, or sugar, neo meaning new, and genesis meaning creation. So the most obvious and commonly recognized mechanism of metformin is stopping the liver from making glucose out of glycogen, which is stored in the liver. It doesn't stop it entirely, it slows it down. But that's not really the only mechanism that we know with metformin. The most common Side effect for metformin is to have some GI distress, some, gas, farts, diarrhea occasionally. In about 20% of the people that take this medication for the first 2 weeks or so when they get started, metformin has been shown to change the gut biome. And it changes the gut biome from a gut biome that's consistent with prediabetes or diabetes to a gut biome that's less consistent. So there's a mechanism there that's not totally understood, but there's clearly a lot of evidence about what might be going on. But that's only two mechanisms of metformin. There's a third as well, and we'll talk about that on the last slide. Metformin actually has an impact on one of the known, or several of the known inflammatory markers. So metformin actually has an impact on inflammation. We'll talk about that as we go deeper. So obesity and type 2 diabetes have an increased risk of severe COVID-19 and death from COVID. We know that. Safe, effective, pardon the misspelling, relatively inexpensive. That's metformin. It's dirt cheap. It has additional anti-inflammatory effects in people with or without diabetes, as we just mentioned. Now, who did this study? Researchers from the University of Minnesota Medical School and United Health Group in Miami, Florida. They analyzed data from 6,256 patients hospitalized due to COVID-19 in all 50 states from January to June 2020. So if you look in the upper right-hand corner, that gives you the process for how this worked. They started with 15,380 records for patients with confirmed COVID-19. 9,000 of them were excluded. Why? Well, 18 because the age was missing, but the vast majority of them, 9,106, did not have a history of diabetes or obesity. Now, again, those of you that have watched this channel know that they missed the vast majority of people with diabetes or prediabetes because most of them don't carry a diagnosis because of the reasons that we discussed earlier in the video. So, and again, as we cut this video down to the shorter piece, just to remind the rest of the group, it's because most docs don't really effectively understand how to diagnose, let alone treat prediabetes and diabetes. So we know that, but that's just something that we need to keep in mind as we watch the rest of this analysis and our interpretation of the findings in this study. That still leaves, dropping that 9,000 still leaves 6,256 people eligible for inclusion. These were people that were admitted with COVID-19 to the hospital, and they had either diabetes or obesity in their diagnosis, admission diagnoses. Now, when you look at that, most of them had no metformin use. 3,923 had no metformin use. Now, again, as we interpret that and analyze it, is that because most people with diabetes are not taking metformin? No, that's not the case. But most people with obesity, with a technical medical diagnosis of obesity, are not taking metformin. So that leaves 2,333 that were using metformin. So back to the bullets on the left-hand side, the aim was to evaluate commonly used medications, this one being metformin, with a good safety profile. And I will say metformin's got a great safety profile for the potential to combat this virus. The patients were divided into two groups, metformin and non-metformin. Just a quick comment about that safety profile for metformin. If you go to the Mayo Clinic website and if you look at some of the FDA black box warnings, you'll see metformin has a warning about a thing called lactic acidosis. Those of you who are a little bit deeper into the science and the evidence might be aware that there's a thing called Cochrane studies. The Cochrane group is a group that does, it's volunteer scientists throughout the world who have looked at meta-analyses, all the research done on a specific topic. This question about metformin safety is a big one. And the Cochrane group is one of the few questions that the Cochrane group has actually done not one, but two meta-analyses, both of them finding that metformin's not really, the science does not support metformin having even a lactic acidosis safety issue. So I'll just, again, before I go further on that rant, I'll leave that alone and move on. So what were the results? As I mentioned before, there was a difference in the overall group, 20.2%, a difference in terms of death rates for the overall group, not just women. 20.2% of the non-metformin group with COVID-19 died, compared to 16.9% of the metformin group. But that wasn't reported as being, as I mentioned in the title, because statistically it was not significant, meaning significance for medical studies is usually assumed to be 5% or 1 in 20. It was a little bit higher than that, so it was not reported as significant. However, once you start going down into subpopulations, you look at the women's group alone, and among women, there was a statistical difference in death rate if they were taking metformin versus not. 21 versus 24%, or a 21 to 24% reduction in mortality among women in the metformin group. Now, if this turns out to be true, just how big of an issue is that? How many women would be impacted? Well, 42% of women in the US fit the official criteria for obesity. We are in an obese nation. And I see that all the time with my patients. People say, you're too skinny, you look sick. Well, unfortunately, what we think looks healthy is not healthy. Again, pardon the digression. So 42% of women in the US fit the criteria for obesity, and 16.2 million women have diabetes, at least have diagnosed. And as we've mentioned a couple of times, more women have it and don't have it diagnosed than women have it and do have it diagnosed. Seeing a big, and that's not even talking about prediabetes, which causes these same risks. So seeing a bigger association with protection in women over men may point to inflammation reduction as a key way that metformin reduces risk from COVID-19. Now, there's nothing statistical or in the data that indicates that. That's just something that the authors were thinking about. Why would we see it more in women than in men? The other possibility is that it was just a statistical variation. But we'll talk again on the last slide about what is this thing? Most people don't know that metformin actually does impact inflammatory markers. So observational studies like this cannot be conclusive. As we've mentioned before, this is just a signal in the literature. It's not conclusive proof. It helps us build evidence. Now, as I mentioned, we were going to mention an article very briefly. This is in a niche journal. It's in Endocrine Metabolism, Immune Disorders, and Drug Targets. Very, very niche, small journal. But it talks about specifically what some of the immune markers are that are impacted by metformin. Metformin impacts the liver, as we discussed. It impacts the mitochondria, as many of you viewers of this channel know. And yes, it does impact inflammatory markers. One of the classic ones being nuclear factor, kappa B, NFKB. You don't see that one mentioned a whole lot, but it's clearly an issue there. AMPK, mTOR, some of the others that you may have mentioned or may recognize if you watch this channel. Yes, those are impacted as well. So there you go. We got a very interesting signal in the scientific literature that metformin may actually have a positive impact on COVID infection, coronavirus infection. Now, a couple of quick clarifications. Most of the folks watching this channel will understand that COVID is not the exact same thing as coronavirus. You know, coronavirus has nothing, catching coronavirus has little or nothing to do with having prediabetes or diabetes. But for most people, you're much less likely to have significant problems with that coronavirus unless you have diabetes, prediabetes, obesity, old age, some of those things. So I am going to, that finishes our program for today. And Gilbert, if you'll give us the water ball, we'll go into Q&A. So, got a lot of interest this morning. Good morning, John. Good morning, Bart. Sorry to hear that it's raining in New Jersey. It's been raining. It's raining all week here in Kentucky. Good morning, Bill. And Robert from the North Georgia mountains. Ali Kamsi, good evenings from Istanbul, Turkey. I appreciate you so much when you tell us where you're from, and I don't remember seeing another commenter yet from Turkey. If you look at our population, our subscribers and our commenters, we're about, I think it's either 57% or 47% from the US. The rest of it, so half of our viewers are from the rest of the world. I really appreciate you you joining us and letting us know where you're from. You know, we were talking about Turkey. I have an interest in Old Testament biblical studies, and I would love to come see Ephesus, the ruins at Ephesus. Unfortunately, because of the travel restrictions, I think that's going to be a while before that happens. E.T. himself, thumbs up. Yes, thank you for the reminder. And guys, if you appreciate this content, doing a thumbs up, and especially putting it in your social media, putting a reference to it, a link to it in your Facebook feed, your Twitter, all of that. And then when somebody actually clicks on that and follows it back to YouTube, the YouTube algorithm, the artificial intelligence on YouTube ranks that kind of connection extremely high. So what happens when you do that is that it says, okay, you know, other humans are seeing this, they're appreciating the content, so we will suggest it to other humans that are watching content. I'd appreciate it. Martha Wright, good day. What's the reason to prescribe metformin ER over regular metformin or vice versa? Great question. So I routinely prescribe regular metformin. There are two issues around metformin that I'll cover real quick. Your specific question has to, the most common thing that I see where people ask for it, where I have ended up using it, and I use it in less than 10% of my patients. It's when they're having a problem with dawn effect, DAWN. That's when you have a high glucose in the morning. About 15 to 20% of people that have a glucose problem have the dawn effect. The dawn effect comes from the fact that most of us get our biggest increase in cortisol at 3 or 4 in the morning, early in the morning, at the dawn. So the way people remember it, I get amused when people say, well, this happened back when we were hunter-gatherers. I don't know how they know that. It certainly makes sense, but that's what people tend to think of. You get, the prehistoric hunter-gatherer has to get up and get the work done, go hunt and gather. Modern man has to get up and go do work as well. So we tend to get a bump in our cortisol. Now, cortisol is a hormone. It's very much like a long-acting epinephrine or adrenaline. It gets us up and going. And as part of getting us up and going, it stimulates the blood glucose to increase. How does it do that? It does that by increasing gluconeogenesis by the liver. And again, for those who are tuning in late, gluconeogenesis is just a long, expensive Latin technical term for making new glucose. The liver does that, and it does that to support activities, fight or flight principle, stress principle. And again, as we just mentioned, we get a what we call a diurnal effect, a daily up and down of cortisol. And for most of us, that's 3, 4, 5 in the morning. Because of that, a lot of people, especially if they have glucose metabolism problems, will have higher glucose in the morning, and it'll actually drop after eating breakfast. Now, I will also say, while I'm going down that bunny trail, as a guy who manages this kind of stuff with patients all the time, I will tell you there's much more heat than light around this issue. Morning glucose, even if you have dawn effect, rarely gets, I've rarely seen it over 135. I've seen it significantly, with some people with pretty bad diabetes. If you have 125 or higher, for fasting glucose, that is one of the definitions of having full-blown diabetes. But the place where you really start getting a lot of damage is 140 and above. And that usually happens after a meal, not with the dawn effect. Despite all that, a lot of people with a dawn effect problem try to manage it and get very frustrated sometimes when they can't. They'll move their dinner meal earlier, previous to 4 o'clock in the evening, in the afternoon. Sometimes that helps. They'll cut any carbs. They'll decrease the amount of food that they eat in the late afternoon. They'll cut dinner entirely. Sometimes that has the opposite effect. But as they continue to manipulate that around, one of the things that we also see is a request for me, well, can I get that long-acting metformin? And that's when I'll end up prescribing it. Now, I mentioned that I had another item that I wanted to mention in this specific area, and that has to do with cost. And it has to do with those charlatans, the marketers of prescription drugs, and not just the pharma, but the guys involved in the secondary market as well. Believe it or not, despite the fact that in most cases, plain old metformin is dirt cheap. In fact, gosh, 8 years ago or more, some of the pharmacies began giving it away, literally giving it away to get patients to come to their pharmacy to fill their prescriptions. So they gave it away as a loss leader, and it was because it wasn't much of a loss. It was very cheap. Despite all of that, some of the most expensive drugs in a managed care formulary can be metformins. And again, it's because some of the marketers, the less than ethical marketers, are just looking for ways to make a ton of money in this medical marketplace. And what they've noticed is that, okay, people have not had much concern about prescribing metformin in terms of cost. they would look at certain types of metformin ER and say, okay, they're going to think that's cheap. It's metformin. We're going to make it very expensive and make a ton of money off of it. So be very careful from a cost perspective when you get metformin ER. Great question, Aunt Martha. James is not here today. James is, Janice hates for me to say this because she hears it so much. He's eyeball deep. He's very focused right now on developing our Alabama Medicare Advantage programs. Well, we're getting a lot of comments. It's starting to get some pressure on that comment feed. And M. Ball, Trial Site News just posted a video with the lawyer who forced hospitals to give prescribed ivermectin. Interesting. Thank you for sharing that. You can have all the greatest things that will help, but getting it into the patient is another thing. There's no question. There is absolutely no question. If you look at it's a great comment, and it gives me a great opportunity to talk about something I'm very passionate about, and that is quality of medicine. Patients tend to blame poor quality of medicine on doctors. And you know what? There's plenty of blame among docs. As we've mentioned all the time, docs don't know how to diagnose effectively some of the key drivers of death and disability. But you know who? Doctors blame insurance companies and patients. And guess what? Insurance companies and patients both deserve a lot of blame as well. In fact, studies have shown that it doesn't matter nearly so much what a doctor prescribes or recommends. It matters what the patient does. So it matters more whether the patient listens to the doc. True quality of care requires that the doctor is able to engage that patient. And in order to engage a patient, usually you have to help them understand what's going on with their health and why simple things like lifestyle may be much more important than anything we can prescribe or supplement or do with surgery. Thank you for your comment, M. Ball. Ann W., hello, watching from Kenya. Thank you so much, Ann, for sharing that. And again, I don't think I've seen comments from Kenya yet either. So we got two firsts today, Turkey and Kenya. Now, I have visited Kenya. I was there on safari. It was an incredible camera safari. There were no guns involved in that or shooting. But it was amazing. Amazing. And here's another thing that was amazing to me personally. I can't remember the name of the town. It's one of the coastline towns there in Kenya. We actually saw a couple of people with leprosy. And I had obviously I'd read about it, but I had just never seen it. So for me personally, that was an incredible trip. Thank you so much, Ann, for letting us know. And I hope I hope it's worth your time. Thank you for your interest. Martha Wright, does lack of insulin cause a body to use muscle as energy and cause a wasting away of the muscles? I'm not, as you can see, I'm struggling on how to answer that. One of the things we do know, that one of the biggest issues that drives disability, especially after age 65, is muscle wasting. So we do know that muscle wasting is a very, very big deal. We also know that tends to correlate with loss of insulin sensitivity. So I can see how you would connect those dots. And you may be right. I have a suspicion, though, that the general processes associated with aging have to do with a lot of different hormones, testosterone and estrogen, for example, both being big issues with aging, and both being a little bit more known to be impactful on muscle muscle mass. But I will tell you, no matter what the mechanism is, retaining muscle mass is critical to health as we get past 50, especially past age 65. This old meme of a sweet little old lady or a sweet little old man, they may be cute, but it's dangerous to be a little old lady or a little old man. You need to focus on getting that muscle in there and keeping that muscle. So one of the things that there've actually been studies done to see which types of exercise are the most effective at decreasing insulin resistance and some of the problems we're discussing. The most important one came up as high intensity interval training. The second most important one was resistance training. Again, both of these focusing on the mitochondria within the muscles and the muscles themselves. And so when I'm talking with patients about longevity, yes, aerobics is critical, but aerobics does not really focus on muscle mass. In fact, if you look at your marathon runners, they do not have huge muscle mass. Aerobics tend to fight against large mass, but increase endurance. That's one of the things that we missed entirely in the 60s, 70s, 80s, up until the most recent decade. We thought it was all aerobics. Big mistake. You got to get muscle mass in there. You got to keep it in there. So I'll leave it at that. We got a super chat. Let me see. That was Tired Looking for Name. Great material as always. Thank you so much. And if others would like to do a super chat or donate to the channel, we really appreciate it. The whole goal for I don't know how to make that show up. The whole goal for this channel is to help people avoid the most common causes. Gilbert, if you'll put on the corner up there the instructions on how to donate. I've supported this channel through my retirement. I've been, at least my version of retired, for a while. We're going to be going back into some other clinics, but even in my version of retirement, I tended to work 60 to 80 hour weeks or more because I love what I do. This version of retirement has been all about this channel. It's been about getting information out to people about the most common killers and disablers in the world, how to recognize them at first, how to assess the damage, and how to reverse that, because it's clearly reversible. And it's not by a pill, although we're talking about a pill today. Pills can be very important and support things, but lifestyle. They did a head-to-head comparison, multiple of them. One of the most recent ones, or bigger ones, was done in the New England Journal, one of the best journals of medicine in the world. 3 years ago, they did a head-to-head comparison, metformin versus lifestyle. Minimal lifestyle changes, loss of 5 to 10% of, not even 10%, I think it's more like 5% of the body weight. Aerobics, not even getting into resistance training or high intensity intervals. And still, that was 3 times more effective than just giving metformin. So metformin helps. There are supplements that help. There are a lot of other things that help, but nothing will get you past a lifestyle issue. And by far the most important lifestyle issue is diet. Kathy Jensen, Kathy Budahiri, good to hear from you today. Great info. How might this change who you recommend take metformin? I don't know that it's going to change my recommendations for metformin. I'm pretty liberal with recommending it and offering it clearly for anybody who's got proven insulin resistance. I would recommend it. I have also done many videos on the TAME study. TAME stands for Targeting Aging with Metformin. I'm blanking on the name. I keep doing this. I keep having these word blocking. Maybe somebody can fact check me and help me out here. I'm blanking on the name of the the principal investigator. It's up at Albert Einstein in New York for the TAME study. And I've done like 3 or 4 videos on it. What they did was they said, you know what, we know we've got a great medication for the most common cause of death and disability as we age. It's metformin. And it doesn't cause problems, and it does a lot of good things. So in the TAME study, they said, let's effectively put it in the water. In other words, let's just give it to everybody at a certain age. They started at age 65. I haven't seen the results yet. I don't know if they're even out. Nir Barzilai, Nirbarzilai. He's the principal investigator. He didn't really come up with the study. The physicians, the gerontologists, the PhDs, the other scientists at the National Institutes of Aging actually came up with the study. And I told you why, the mechanism behind it. That study had the most trouble getting funded, and it was because there's a bureaucratic law at the NIH that says you can't fund studies for anything except a disease. And their point was, this is for longevity, it's not for a disease. So it's like, stupid things get in the way of smart things all the dang time. John so anyhow, Kathy, I'm pretty liberal. And where I was going with that TAME study is that a lot of people have talked about preventive metformin. David Sinclair, one of the top 5 most well-known longevity experts in the world, I think he's got co-appointments at Harvard and MIT and some university in New Zealand where he came from, or New South Wales. Pardon me if you're in Australia or New Zealand or South Wales for my lack of awareness of that part of the world. But David Sinclair, look him up, took metformin, even though he did not have known prediabetes or diabetes. He took metformin starting at age 50. I don't know if he's gone off of it. There's been some back and forth about, oh, well, you know what? Maybe it damages or hampers the mitochondria a little bit. I don't really think, I think that concern has been overdone. So thank you, Kathy. It was a great question. I hope this helped people begin to understand a little bit more about the questions of when to take metformin, even considering it on preventive basis is a basis after age 50. I give it to a lot of people who are interested in taking it for preventive reasons. John Tucho, consider joining Patreon to help Dr. Brewer's channel. Thank you so much, John. I appreciate that. As I've said, I first of all it takes some money and resources to do the channel. As you see, I'm not the only one managing the technology, for example, for today. We've got Gilbert there. I'm not smart enough, especially in the tech field, to juggle all this and the content and my word finding problems and all of that other stuff. So Gilbert lives in the Philippines. Gilbert, you want to say hello?
Hello.
So that's Gilbert. He helps us with the YouTube Live. Aspen helps us with the YouTube Live. Even a $10 donation like we got from Tired of Looking for Name a few minutes ago. Because we're doing arbitrage between the economy in the U.S. and the economy in the Philippines, any little bit helps in terms of getting this content out there. And as you can see, with what's going on in the background, the technical aspects, they say content is king. It's very true. But the technical aspects of how this is presented is very important to people. They really don't like, I'm classic for writing something on a piece of paper and holding that shaky paper up in front of a webcam. People don't like that. Some people do. They call it the old style stuff. But people do like production value, and that production value is all due to Gilbert and Aspen and the folks that are helping us do this channel. So again, contributions, whether Patreon or just PayPal contributions, the other contributions do make a difference. Thank you so much, John. I appreciate that. Martha Reich, I've liked and shared on Facebook already this morning. Thank you so much, Aunt Martha. I appreciate it. Robert Weiss, we keep saying has diabetes, but almost zero Kraft insulin surveys. Everything is based on the A1C, which we know is sloppy at best. Thanks. Thank you for bringing that up, Robert. So for those of you who are not in on what Robert's saying, let me interpret some of that for you. So one of the bigger problems, we mentioned docs don't know how to diagnose it. The vast majority of screening, that's number one, most people by the time they're age 60 have some level of insulin resistance, over half. And that's as measured by A1C or fasting glucose, which is even worse. In fact, if you look at JAMA, there was a JAMA article a couple of years ago which showed that even from ages 30 and up, over half of Americans, we're not talking about 60-year-olds, we're talking about 30-year-olds, 30 and up, over half of Americans have some level of prediabetes. And as Robert's referring to here, most of them get screened by mechanisms that are not adequate. They're not appropriate. They're really bad. A1C is even better than the most commonly used screen. And the most commonly used screen is fasting glucose. A fasting glucose, most labs will say over 100 means prediabetes, and over 125 means full diabetes. The reality is over 90 means prediabetes. You should at least start looking very hard if your fasting glucose is over 90, clearly over 100. A1Cs, 6.5 and above, full-blown diabetes. Now, then you get into argument. So was it 6 for prediabetes or 5.5? You start getting close to 5.5, and I start worrying about prediabetes. It's crystal clear. There are several things that most doctors think that A1C is the state of the art. Well, if you look it up, it's not just me saying this. The American Association of Clinical Endocrinologists, AACE, is also pretty clear that to make the diagnosis of diabetes or prediabetes, as Robert is saying here, A1C is inadequate. And here's why. Anything that impacts your hemoglobin can impact your A1C. You see, A1C is what we call an AGE, advanced glycation end product. An advanced glycation end product is simply a protein that glucose has permanently latched onto. And that's what glucose does in the blood. It latches onto proteins. I used to have a diabetes instructor in med school, and he'd pull out a piece of plastic from his pocket when he was teaching about diabetes. It was a plastic model of a muscle, and he would say, "This is your muscle on diabetes." And he said, "You think I'm kidding or being, I'm not. Diabetes actually plasticizes our body tissues. The glucose glucose tends to latch on permanently to protein, and it denatures it. If you want to know what denatured protein is, fry an egg. That's what denatured protein is. Before it's fried, it's not denatured. Once it's fried, it's denatured." So now you can start to latch on to his analogy there. As Robert Weiss mentioned, there's a thing called the Kraft Insulin Survey. What we want to do is get a moving picture of glucose. And a Kraft Insulin Survey looks at fasting, glucose, and insulin levels. It then looks at glucose and then gives you a challenge. The typical protocol is to give you 100 grams of glucose in a sweet, syrupy tasting drink. Then measure your glucose and your insulin at half an hour, 2 hours, 3 hours, and 4 hours. Now, we do something very similar in our routine testing for this. We can't access, we've got a couple of different ways where we're accessing something similar. We're working with a company called I'm Aware now to get a simple, easy home version of it. You can do a home version with a lab called Meridian Valley Labs. What we routinely do is do a similar craft survey using just 1 and 2 hours and 70 grams of glucose from Quest Labs. That really gives us the information. Now, some of the more academic people watching might say, oh, that's crazy. You don't have to do all that. Just do a HOMA-IR. I see HOMA-IR ratios all the time that look totally normal. A HOMA-IR is just a ratio between glucose and insulin, usually in a fasting state. The problem is it's a still picture. It's not a moving picture. And you know what? You could take a still picture of a car getting ready to run over somebody, and that person's going to be fine. But you take a movie and you see that the person just got run over. It's the same concept with HOMA-IR versus this type of glucose challenge. You really need to do the full challenge. Thank you, Robert. That's a great question. I appreciate you bringing it up. Martha Reich, have you ever prescribed regular metformin for morning dose and Metformin ER for evening? I haven't done that. That's sort of what you're doing then is you're giving an immediate dose in the morning and more of a 12-hour dose in the evening. So you're going to get a major bump in the morning and not so much the rest of the day. I mean, I'm not saying I'll never do that, but I'm struggling over when that situation would arise. Ali Kamshi, thank you. Thank you, Ali. And I think Ali was from our visitor from Turkey. James Cantor, James, metformin ER causes less digestive issues. I enjoy using it. Thank you, James, for sharing that. And I didn't mention that. A lot of people do get a lot better GI impact, gastrointestinal impact, as you said. Bill H., I think that might be Bill Hart. I'm not sure. The dawn effect for me goes away dramatically when I sleep well, regularly. One bad night of sleep, especially 2 in a row, gives me a noticeable dawn effect. You know, that's a great point too. Thank you for bringing it up. I'm probably talking too much, but you're bringing up some good points. If you read the book, Why We Sleep, somebody help me I'm blanking on the name of the author. He brings up a really good point about sleep and diabetes. There's some studies that have been done that show you might have basically normal glucose metabolism and then have a bad night of sleep, which you might not even notice, but recorded as a bad night of sleep in the sleep lab. You'll get an increase in prediabetes, insulin resistance for 2 days associated with that. Now, some people might ask why. I think, the immediate assumption might be that there may be some challenges in your cortisol when that happens. I don't know that that's been proven yet. James Cantor again, metformin has not been more expensive in my Blue Cross SC, I think maybe Blue Cross Blue Shield. James, yes, you're correct. And maybe I overstated the case. The vast majority of ER extended release metformin is no different for most people in the U.S. on U.S. insurance. And it's not really that much more expensive for people who are paying out of pocket. The only reason I brought that up is that, again, that's like a little snake in the grass. Sometimes you didn't see it happening, and some marketers tend to use that. So just be very careful with it. We've actually gotten stung. A couple of our patients almost got stung with that. And that was the reason I brought it up. Thank you for bringing it up. No, ER is not usually that much more expensive, especially if you're insured and you have an insurance company that's doing mass purchases for you. James also says metformin ER has not. Okay, so Bambi Grage, good to hear from you, Bambi. Good morning. Had my OGTT and inflammation panel last week. See you on the 17th. Bambi, I don't know that we've seen each other before, and I'm so excited. Thank you for letting me know, and thank you for letting the others know as well. Robert Pinsky, what do you think of taking DIM for anti-cancer and or as an aromatase inhibitor? DIM. Now, I'm not going to be much help on that, Robert. I'm not that familiar with it. I'm going to have to pass on that one. Mezzanine, so true about the dawn effect. Bill H. Star Rider Studios, good question. Jeff Clifford, watch your plaque video. You're right. It's all about inflammation, exercise, and statins. I take atorvastatin, 40 milligrams, but now lowering wheat breads too to stop insulin resistance. Thank you, Jeff. So he's talking about taking the plaque video or maybe the plaque course or watching the plaque video. Most of this content is available on the channel. Most of the content that's even in the courses is available on the channel. Here's the problem, though. It's a problem of curation. There's about 1,000 videos on the channel, and if it's worth the $30 to $50 to just to get stuff where I've curated it, put all the right stuff, retaped it, specifically to that course and that organization. Now, Jeff, I would say I've used atorvastatin, Lipitor, maybe twice in my career, and here's why. It lowers LDL really well, but it doesn't. And it does lower cardiovascular inflammation. It does manage it, but not so well, not nearly so well if you have prediabetes, which most of us do, or if you're a female. I would recommend consideration of rosuvastatin or Livalo. I'd also recommend considering lower. I usually recommend that folks consider lower doses because the lower doses of these statins actually deal with the CV inflammation. You don't need the higher doses to deal with that. This is Tired looking for name, the super chat. Thank you again for that. I appreciate it. And it'll help get that information out to the world, which is where this is going. I keep hearing that metformin causes mitochondrial damage. Is it possible to discuss this? So yes, I started to mention some of that before, and thank you for asking. If you follow, there's a lady that is really deep into supplements, micro supplements. I'm blanking on her name right now. I'm a big fan of hers. She's mentioned that a couple of times. And yes, there is some evidence that that metformin stresses the mitochondria. The question is how much and how big of an impact. It's just like everything else in life. What is the trade-off? What is the benefit? What is the risk? I personally take metformin. One of the questions is, does it those of us who've looked a little bit deeper into it would say, well, if you're an Olympic athlete and you're looking at that level of muscular activity, maybe you should reconsider metformin. But, there's not a lot of Olympic athletes that are watching this channel, at least that I know of, and they're in the age category. If you look at our our viewers, over half of us are 55 and older. That's an unusual age distribution for a YouTube channel, but it's all about aging and plaque and aging healthily. I have had several 20-year-old patients, and it's really refreshing and nice to get those because, unfortunately, this problem does start much earlier than most people think. I'm gonna leave that, and if there's a lot of interest, a lot of requests, I can go a little bit deeper, maybe find some articles and go into more detail about the potential for metformin stressing mitochondria. On a practical basis, people often ask, well, what do you do, doc? I do take metformin. I'm one of those guys that even though I've got a low BMI, I've got fairly good musculature for a 63-year-old. I still have significant insulin resistance. I take both metformin and pioglitazone. I do a thing called pulsing both of those. I don't take either one of them every day. I have a bi-weekly, I do my high intensity intervals between 2 and 3 times a week. I used to not take my metformin on those days. I've then switched it up, and I'm not seeing a difference personally on days when I take metformin and days when I don't. And I do have fairly intense high intensity intervals. I do hill runs. I'll do quarter miles at a 6-minute pace, running pace, which is pretty good for an old man. Eric Jones, diabetes and muscle loss, Science Daily. Thank you very much, Eric. You know what? I would like to see that article. Hopefully we can go back and find that. Like to do it's an item of interest to me. I'd like to do that for one of our specific programs. Emmett Carney, hello from Chiang Mai, Thailand. Oh my goodness, we've got 3 new countries today. Thailand, Chiang Mai, thank you, Emmett. Kenya and Turkey. Now, just to let you know, we've had folks from Austria, China. I've got patients in Singapore, Australia, Brazil, Israel. We've got them all. Again, we've got viewers and patients all over the world. Thank you so much, Emmett, for telling us where you're from and for your interest. Robert Weiss from the North Georgia mountains in the U.S. Agree with previous comment about quality of sleep impacting blood glucose morning reading. Yes, it does. Bob Bell, in Go Darts, each 1 gram per day of metformin use was associated with a 2% higher annual risk of anemia. Yes, that's a very good point, and I rarely talk about that. Thank you so much. In fact, I wasn't aware of it until fairly recently, and I think it was you, Bob, that made me aware of it. Now, in most folks, that anemia is not that big of a deal compared to the other benefits. As we said before, everything in life is a risk-benefit question. Anytime you go out and you get in your car, you're increasing your risk of death from a car wreck. So, and we on a regular basis realize that, and we say, well, you know what? That's true, but I want to go to the movies tonight, and I need to get in the car to go to the movies, so I'm going to take that risk. For some people, though, especially people with certain types of cancers or other types of issues, it's pretty unusual for folks to have the issues where this anemia has an impact, but it happens. And again, thank you so much, Bob, for mentioning that. Martha Wright. Hey, Gilbert. Okay. Thank you, Martha. John Tocho, 80 people watching and only 30 likes. We can do better. I agree. And thank you so much. You know, it's so interesting. It's not like the computer's going to bite you. It's not like some sort of AI is going to come back and trace you. But, people are very hesitant to interact. I appreciate you pointing that out, John. Bart, yes, please, everyone, pound that like button. Yeah, it's been the past 5 years or so. They like to say, smash that like button. Gilbert, if you'll pop up and show them the pop-up on how to do that, I'd appreciate it. Samir Abumad, I believe glucose tolerance test should be the test to diagnose diabetes more than A1C. You are so right. Glucose tolerance. And in fact, even more so, the Kraft Insulin Survey, which somebody mentioned a few minutes ago, and the difference between a Kraft Insulin Survey, for the most part, is it looks at insulin as well as looking at glucose. And both of them look at it when it's challenged. You challenge the body. First, you fast for 8 hours or more, and you take the fasting glucose and insulin. Then you do that 70 to 100 grams challenge, and you say, well, that's just, that's artificial. That's what a lot of doctors like to say. That's what John Lorscheider's doc said. Well, these are artificial. They're rigged to fail. Well, if you look at it in context, you get a large Coke. I'm not talking about an extra large. I'm talking about just a large Coke. At McDonald's, 76 grams of sugar. So people are nailing themselves with a glucose challenge more than once a day. I mean, how many large Cokes are being sold by McDonald's alone in the US alone every day? So thank you so much, Samir, for giving me an opportunity to rant about that. Bill H, yes. So I think you're saying yes, Hart is my last name. Thank you so much, Bill, for sharing that. And pardon me, I had already said it before. I thought you might not even want people to know. Thank you for sharing. Jeff Clifford, reduce wheat as in wholemeal bread, and that will help with electrolyte absorption. Jeff in the UK. Thank you, Jeff. And I've got patients in London, by the way. So Jeff, thank you for bringing it up. I don't know the exact numbers. And again, somebody can fact check me. But when people start hearing they have a problem with glucose, they say, well, you know what? I'm going to use less sugar, 1 teaspoon instead of 2. Or a teaspoon instead of a tablespoon in my coffee. That really has little or no impact. More often they'll say, okay, so I can't eat desserts now. Again, even desserts, much less of an issue than grain products, breads and pastas, pizza, beer, sandwich breads. And then what people will say is, like to your point, people say, oh, well, eat whole wheat grains. Look at the glycemic index on a whole wheat piece of bread versus white refined flour bread. We're talking about what? 67 versus 76. I mean, it's like where glucose itself is less than both of them. So don't fall to the whole grain products deception. I'm not saying that it's a purposeful deception, but it's a deception. Bill H, Why We Sleep by Dr. Matthew Walker. Thank you so much. You're exactly right. JR, check thumbs up, everyone. Thank you so much, JR. I appreciate that. And that wouldn't be our JR, would it? From London. Vagabond Sojourner, my glucose and insulin have gone up about 100 consistently since starting treatment. What kind of treatment? Ideas? Yesterday, 115 fasting, fasted glucose, and 8.3 fasted insulin. Up 100? This can't be right. Maybe you mean 10. Because that would have meant your previous number was 15, and that's lethal. If you could help clarify, Vagabond. And one thing I will say, I do see this all the time. People start making huge progress. They start making lifestyle changes. They start dropping their body fat. They start getting confident, and then they notice things start getting worse. Well, you know what? We're getting older, and aging in and of itself is the biggest challenge for insulin resistance. Obesity is a big deal. Most people think that it's the obesity epidemic that's creating the diabetes epidemic. It's certainly helping, and it's certainly number two, but number one is aging. And the alternative to that, I'll leave that alone. Mezzanine, berberine, ACV at bedtime to help mitigate dawn effect. Yes, that's a good point. Some of the supplements, garlic, cinnamon, especially cinnamon, berberine, and bergamot, all do have some impact there. Shut up and get out. Well, that's not the friendliest name. Dr. Rhonda Patrick, thank you so much. Shut up and get out. Rhonda Patrick was the one I was talking about. And if you go to her channel, she's got a lot of details on it. She trained with one of the eminent guys in nutrition, micronutrients. And she's a specialist in micronutrients as well. DCAP, I heard our body becomes dependent on metformin after a while and will need to add other meds. We often need to add other meds, but it's not because you're becoming dependent or addicted to metformin. It's because you're continuing to age. Like we said, aging is that major driving force. So no, it's not true. Will my body become dependent? Or no, it does not. Does the pancreas forget how to make insulin? No, that's not usually the case either. It doesn't forget. Here's what does happen. Our insulin receptors in the cells of our body, our livers and our liver and our muscle cells, those insulin receptors get rusty. They get resistant. They don't respond to insulin as well. I see we're going on today. I've got a little bit more time. I'm going to go ahead and cover the rest. We've only got a few more comments. Caroline Morris, good afternoon from remote Wales. Good afternoon to you as well. Now, I didn't know there was a specific remote Wales. I knew there was a Wales. I'll have to look that up. Decap, just liked it, forgot. LOL. Thanks. DL, what does your liver have to do with heart health? How does it affect cellular integrity? I'm trying to learn how oils, fats, and sugar are metabolized. Natural fruit sugar and not produced sugar. So most fruit sugars are fructose, and they're very different from other types of sugars. They actually go straight into the liver, and they actually do appear to cause deposition of fat in fatty liver. We don't cover fatty liver very much. We've had a guest, a physician named Kevin McCord, who should be joining us some more in the future, on some more guest appearances at least. Kevin's a big advocate of looking more deeply at fatty liver. Most of the things that cause fatty liver, it's a big deal. We've got a few videos on it. In addition to fructose, most of the things that cause fatty liver are very, very much associated with prediabetes and diabetes. So the things that you do to manage prediabetes and diabetes, like losing body fat, increasing body muscle, decreasing carbs, any kind of carbs in your diet, whether it's fructose, glucose, or sucrose, all those things tend to help. Now, what does the liver have to do with this? The liver makes glucose, and the liver makes glucose in response to a sort of a thermostat. It's a cell nucleus in your brain. And that cell nucleus says, okay, this is the right level of sugar in our blood. And when we're young and we're just getting started, usually that tends to hang around the 80s, unless our mother was diabetic or pre-diabetic when we were pregnant, when she was pregnant with us. That cell nucleus in the brain gets adjusted. So as we start getting resistant, our receptors start getting resistant to insulin, our blood sugar starts going up. that cell nucleus starts getting used to having your blood glucose averaging in the 90s, then in the hundreds, then in the 110s. And when we start, somebody who's used to having their blood sugars in the 110s, when they go down to even in the 80s, they can start feeling hypoglycemic and hungry and needing to eat. After you start managing your blood sugar better, this takes months for this thermostat to adjust, but it does. You'll start seeing people who have been they've been on a keto diet, they've been managing their blood sugars on a low carb diet, may or may not have been using metformin, doing the other things to manage their blood glucose. You'll see them on a Libre, they start getting down into the 60s and even 50s at 3 or 4 in the morning, and they never noticed it. In fact, they said, I slept better last night. They'll even get into the 60s and even 50s during certain parts of the day, and they'll say, didn't notice it. Or maybe a little bit tired, but overall just didn't notice it. That's the mark of somebody changing their metabolism. You'll hear a lot of it. You'll hear a lot about it, but you'll hear it referred to differently on the internet. You'll hear it referred to as fat burning versus sugar burning or glucose burning metabolism. And we see it, with our patients we document it. They document it for themselves. Great question. Thank you for giving me that opportunity to yammer about that. DL, please explain how lipid balance affects cellular membrane and also how electrolytes do the same. Which is more important? The reality is, I will have to say, I think that insulin and glucose balance trump both of those, lipids and electrolytes. And they, in fact, drive lipid performance or lipid balance. If you look at, I've done a few videos on how glucose driven metabolism tends to increase triglycerides, decrease HDLs, and shift our LDL particles. So one of the most telling telltale signs of diabetes or glucose-driven metabolism is a high triglyceride over HDL ratio. I won't go further on that bunny hole. Mezzanine, share and recommend your channel to friends and family. Thanks for what you do. Thank you so much, Mezzanine. I appreciate that. Samira Abumaid, I'm diabetic. Although I control my blood sugar all the time, small wounds or mosquito bites take a long time to heal. Do you think the same thing is happening inside the arteries of a diabetic as inflammation? Exactly. That is what's happening. And thank you so much for sharing it. And you know what? A little bit of that problem is not something that we should be ignoring, but so many people, their doctor says, well, you got a little bit of sugar, we'll worry about it later. Don't do that. That causes this problem too, as well as risk for heart attack and stroke. David Drake, McGovern, Ansel Keys, American Heart Association, American Diabetic Association, government authoritarianism, and why we are all fat and diabetic. Yep. No other comment, and have heart disease. But you know what? I will say this. We can blame them forever, but at this point in time, especially for those of us watching this channel, it's now our responsibility. Forewarned is forearmed. Archer, that may not be, well, anyhow, let me move on. Archer Joelson, I have been on a keto diet with IF, intermittent fasting, for a little over 3 years and have lost about, let me stop to give this some emphasis, 140 pounds. 140 pounds, keto diet and intermittent fasting. And I can tell you guys, pardon me, I'm going to digress for a second. I have never seen so many people that have lost so much weight until I started doing this channel. They come to me and they've lost, they've got plaque in their arteries, but then I look at their OGTT and it looks fine. And I'm thinking, In the beginning, I used to think, what in the hell? What happened with this person? What's going on? Well, now I know. Yep, this is probably somebody that lost a lot of weight, 30 pounds or more. Well, David, one of our frequent viewers and contributors, shared with us he's lost 150. So we got some people losing significant weight, and almost every one of them have said the same thing that you said, Archer Jolson. First of all, they dropped the carbs in their diet, so their blood sugar stopped doing this business. Anyway, it stopped going up and down. The second thing they did was started doing a little bit of intermittent fasting. That's the most common thing I hear, and people are losing tons of weight with it. Still need to lose more and stay vigilant. Yep. This is not a sprint. It's not even a marathon. It's much longer than a marathon. Marathons last a few hours. This lasts for decades. Tired looking for name. I heard that fructose goes through the same metabolic pathway as alcohol. There's similarities. Yes, that's very true. So we have gotten to the last comment. Thank you so much for your interest today. And we'll see you next week. And we'll have some short snippets for you in the week in between. Thank you so much.